morning or good afternoon, everybody. For those who don't know me, my name's Jane Beach. I'm the lead professional officer for regulation with Unite, and I'm joined by my colleagues, Obi and Sarah. Obi, do you want to introduce yourself?
Hi everybody, I'm Obi Amadi. I'm lead professional officer for strategy, policy and equalities, and really pleased to be joining you all this afternoon for the conversation.
Thank you. And Sarah?
Hi everybody, I'm Sara Kovach-Clark. I'm the Assistant Director responsible for policy at the NMC, and I have overall responsibility for our English language policy.
Lovely, thank you very much. So this afternoon we are talking about the English language consultation that the NMC have currently got in progress that finishes on the 12th of August. Just a little bit of housekeeping. If you want to ask questions, please put them in the comments, and Dave Monday we've got behind the scenes will be sending those to me so we can ask them of our panel. And if you want to tweet, the hashtag is UIH Live. So please, hopefully you will find this informative, and please join in the conversation. So we decided on this occasion to include all of our membership in the invite for this event, rather than just focus on our Nursing and Midwifery Council registered members, because obviously all of our members are potential users of the health service. And obviously communication is a big part of that. But we recognise absolutely that it's a really difficult time for members at the moment. Obviously, you are all exhausted after working through COVID, and obviously we're all dealing with the issues around the recent pay award. And just to say, there will be a lot more information on that coming out to you very soon. So please make sure your membership details are up to date. But can I just ask you, Sarah and Obi, why should people engage with the consultation?
Well, I suppose from my perspective, from our perspective, we've had 31,000 responses to the consultation from a whole variety of different people working within the health and social care sector, people who are already on our register, people who want to come onto our register, and employers as well. And I think the significance of this is, it's the most responses we've ever had to a consultation in sort of relatively living memory at the NMC. And the significance of this is because it's a very significant part of our requirements for people to join the register who have been trained internationally, so people who've been trained outside of the UK. And it's and they are a very significant part of our workforce. So it's important that we listen to what people we want to hear what people have to say about it, and that we listen. It's quite a contentious issue. It's a real challenge to get the balance between making sure that everybody who's qualified to get on our register is able to do so quickly, but at the same time maintaining public confidence in the professions and protecting the public, which is essentially our statutory purpose. So that, from the NMC's perspective, that's why we want people. We're happy with the 31,000, but we want more people, as many people who are interested in this, to respond.
Mm-hmm. And yeah, what do you think?
I think that it is a really, really important but very, very contentious, delicate consultation, because in terms of kind of English language requirements for registrants, we've had in the past an application process that didn't require it. Then we had one that did, and then there were the issues about if you were in the EU, it was different. Now we're not in the EU, it's again become, there's been a change again so that it applies to everybody. And there are a lot of people who have been through the different processes who have a view about whether they felt it was fair or right. And we have those who have not been successfully through that process, who again have, quite strong feelings. And it is a really difficult one, because we need to, I think, remove ourselves from getting caught up in the personal view, although it's, we have to consider people's personal circumstances, and think about what is best for the client, the patient, the service. And that can kind of, create a lot of discussion and debate.
Brilliant, thank you. So obviously we do want all of our members, whether they're regulated or registered or not, to give us their views, so we can put those in the consultation. So Sarah, to start off, so we can explain to to those people who may not know much about what the issues are and what's being asked, can you just start off by just talking a little bit about the consultation in particular, just where you've got to where you are and
No problem at all. I think just to start off with, it's important to note that everybody who applies to our register, whether they've been trained in the UK or trained outside of the UK, has to satisfy us that they have the necessary language skills to practice safely and effectively. And if you're trained in the UK, you're able to do that through one of our approved programmes. You're trained outside the UK, you're able to do that as well, as long as you can demonstrate to us that your course was taught and examined in English, and that there was a part of that course had a clinical element to it, and that you engaged talking to patients, people using services, their other healthcare professionals in English. Now that could be quite hard for people outside the UK to do. Most of the time, people will provide us with the evidence that we're looking for through one of the tests that we accept, one of the language tests we accept. And those are the IELTS test and the OET test. So the IELTS test is the International English Language Testing System test, and the OET is the Occupational English test. And so most people do that, but there's a third option whereby if you have been working in a majority English speaking country for at least a year as a registered practitioner, then you're able to use that as evidence of your English language. So what we're proposing to do at the moment, and I'm just going to briefly run through these just a few slides, not too many. And just want to say that these slides are taken from a webinar that we did a couple of weeks ago. And we will post a link, or send the link to you later on so that you can see the full webinar and that conversation. One of the key and possibly the most controversial proposal is that we're thinking about accepting an employer reference as supporting evidence for people who don't quite pass the test. We've had a lot of anecdotal evidence to say that there are people who have been British citizens living and working in the UK. They're trained in their country of origin as nurses, but they haven't been able to pass the language test. And so instead of working as nurses or midwives, they're working as support workers, healthcare support workers in the system, and they feel that this is unfair. So what we're suggesting is that if you are in that position where you just can't quite pass the test, and we do know that we all suffer from exam fatigue and exam panic, so it's quite possible that people can be perfectly capable of speaking good enough English to practice safely and effectively, but still not quite make the grade. And what we're saying is that actually we're thinking of accepting an employer reference for those who missed that test score by 0.5 or half a grade, or people who are trained in English, but in a non-majority English-speaking country. And by that, we mean a country which the Home Office doesn't recognise as being majority English-speaking. And the reason we do that, we're thinking of doing that, is because an employer reference will be able to say is, yes, they were trained in India, but I've witnessed them working with patients, with other healthcare workers, and I am satisfied that their language skills mean that they can practice safely. So we obviously need to put some boundaries around that to make sure that it's safe. So we're suggesting that applicants must have worked for at least a year within the last 2 years in a health and social care setting in the UK, that their referee must work in the same organisation, be an NMC registrant so that they know what the code mean, what's the relevant standards, and in a leadership role. And then we want a senior registrant also at the same employer to countersign the reference, so that means that increases a level of objectivity in there. Because when we've explored this in the past, people have said, well, how do you get them to be consistent? How do you get them to be fair? What if someone's been, not getting what they want from their employer, or what if an employer is just, desperate to get somebody on the register? What boundaries and safeguards do you put in there? So we're asking people what they think about that, and we're also asking how we can ensure greater consistency. And we're also asking a broader question as to whether these employer reference should be used on their own, because some regulators do use them as evidence on their own. So that's one aspect that we're talking about. The second point is also around postgraduate qualifications. And what we hear from people is that, you know, I've got a master's degree and yet I can't pass this test. So, you know, how ridiculous is that? So we're thinking, well, should we accept postgraduate qualifications taught and examined in English? We'd want them to make sure that it covers all the aspects of language, so reading, writing, speaking, listening. You know, does it work in the healthcare system? You know, is it relevant to the healthcare system? And should we accept any qualifications that are outside the disciplines of nursing and midwifery? Because there might be some related, something in a scientific methodology or something else that might test all those language skills. But does that mean you can speak, you know, you can communicate effectively in English through within the health and social care setting? So that's the kind of key question there for us. And then the third bit is around test combining in scores. So at the moment, you can combine 2 test results as long as in each of the 4 domains, if you take 2 test scores together, you've hit the necessary mark in each one. And those 2 tests have been taken within 6 months of each other. We're thinking of extending the period to 1 year rather than 6 months. And again, that's to allow people to kind of draw breath and, you know, these tests aren't cheap. So, you know, get the money together and just think about, you know, they're trying to do a day job and manage families and all sorts of other things. You know, if they can take the test within a year rather than 6 months, I think that, you know, we think that might be fairer. And just a very small and technical boring points, but we amended the writing score for IELTS and OET back in 2019, but we forgot to adjust them for the test combining proposals. So we're just trying to fix that anomaly through this consultation. But the key point is using those test combining within 12 months rather than 6 months. What we're not doing at the moment is changing individual or overall scores that we require for language tests. We've asked a question about that. So, you know, if that's something that you feel strongly about, please answer that question. We did a standard setting exercise with the occupational English test providers, the OET, and they, you know, they suggested that potentially the speaking element could be amended, but they felt we needed to seek other evidence. So we're using this consultation to try and seek some other evidence. And if there's a strong view that we haven't got the right level, then we will do some more work in that area. But those are the kind of 3 elements that we're looking at in terms of the consultation proposals.
Thank you, that's really interesting. So, I mean, a couple of things from me. I mean, which test do people sit, Sarah? Is it, you know, is there a lot of difference between the tests? Does it make a difference which test you sit and how is it decided?
So that's individual choice. So the IELTS test is a broad test. It doesn't focus particularly on healthcare. So I think a lot of criticisms of that test are that they asked me to write an essay on beekeeping, for example. You know, what's that got to do with my job? Whereas the OET is a test that has been specifically designed for nursing and tested with nursing professionals. You know, so the questions are tested with nursing professionals. It's got a much more health and social care aspect to it. So when we only started accepting the OET from 2017, so obviously it's taken a while for the OET to catch up, but we're starting to see more and more people take the OET, and it's a matter of individual choice.
Right, okay. And if we go back to the proposals around having employer references, I mean, I can see that potentially being problematic in, I don't know, certain settings. So you think of primary care, you know, there isn't always another NMC registrant there. And, you know, I'm sure there are many other settings where, again, that might be an issue. So, you know, is it practical? I mean, you know, how are you going to get around situations like that?
I think that's the difficulty for us, and that's again one of the reasons why we haven't pursued this in the past. we had some very strong feedback that we ought to consider this. So that's why we're considering it. We think it could work very well in an NHS trust, but we are concerned that there might be some challenges in primary care trusts, in social care in particular. And so we are trying to reach out through the consultation to try and see what ideas there are out there for this to work effectively across all sectors. I mean, there's an argument to say, well, if it can't work across all sectors, we shouldn't implement it at all. The other counter argument to that is, well, there's a lot of people who work in the NHS. So at least if we could do something to make it easier for people in the NHS, that's something. We don't, we haven't got a view on that at the moment, but those are the sort of things, questions that we're trying to debate at the moment.
And Obi, can I just bring you in? So, I mean,
Yeah.
what are your views on this proposal?
Well, I mean, in terms of the proposal, I mean, for me, the first question should be about whether employer references should be introduced, and if so, let's look at how that might happen and who the people that would sign it off would be. But we don't have that question. It's just jumped in. So, I mean, I'm glad that, Sarah, that you're saying that, it's not a given, it's something that's being considered, because when you're working in a nursing home and there's only one RGN registered nurse there, how is that going to work? It's, there are a lot of difficulties in many situations. We have and we know, because we hear it often, about employers who put pressure on staff to sign candidates, applicants off as being, able and being safe, because they spend a lot of money training and supporting, and they want that person in their workforce doing, the registrant role as opposed to a supporting role. And, they've spent money and they want their money's worth, they want their money back. And although not every employer is guaranteed to be doing that, there is an element where that happens. I mean, we've had, even in terms of other situations, where staff would be miscounted just so that their numbers would look good. There are things that people will do as a means to an end. So even though having a two-stage assessment, validation or whatever, is better than just having one, there are still, for me and for the people that I've spoken to, there are still a lot of concerns around how that would work. You also have the issue about, if somebody is not liked, if they don't get on, will they be judged fairly? Because again, the person who does the final sign-off is relying on whoever it is that does the first signing off. If there is an issue, they wouldn't necessarily know that. So those are, just a couple of things that I think are kind of quite concerning.
Yeah.
I mean, I can I keep talking? Because I will.
You can keep talking, yeah.
Okay, that's great. I mean, again, one of the issues that we are all too aware of and we are quite concerned about is, in terms of fitness to practice, the number of fitness to practice referrals that are ethnic minorities. In terms of these, these overseas applicants, yes, I know that it's kind of worldwide, it could be, but at the moment we know that there's a particular focus on, people coming from, the Indian subcontinent, from, the Philippines, and from Africa, who are wanting to go on the register. And we know that those are some of the people, the registrants, who are almost overrepresented in fitness to practice. So again, we need to take a lot of care in changing the way that they are going to be, assessed and accepted onto the register, because we do not want those numbers to go up, because the unintended consequence of some of these changes means that, it's not quite as, I don't want to say the word stringent, but there are weaknesses within the process.
I think it is, you're right, Obi, it's always difficult, isn't it, to identify all of the unintended consequences, you know, but it's so I think we need our members' support in coming up with issues that they could see could be a potential, because you're absolutely, I think the ones you've identified, absolutely right. I don't know if you want to come back on that at all, Sarah, or?
Yes, I do. I mean, I think that the points that Obi's raised are very pertinent. It's a very, very finely balanced issue. I think when this was first raised with us again, our response was, well, it's potentially open to discrimination, because it was felt, you know, by our stakeholders, or some, you know, a big group of stakeholders, that potentially our processes were discriminatory, and that's why we needed to introduce an employer reference element. But there is, from my mind, also a risk, if you're not careful, of employers behaving in discriminatory ways, either putting, you know, giving people references that they shouldn't give, or holding back references. And you know, I could envisage somebody who is a very good trained nurse, but you know, is cheaper to employ as a healthcare support worker, for example. And why would I bother, you know, giving her a reference and having to pay her more money, or him, for example? So, you know, I think there are issues either way, and that's why we are, you know, consulting on it, and we will think very carefully before we make these, before we recommend making any changes. And I probably should have said at the start, it's actually our council. So these proposals will be, or the outcomes of this consultation will be presented to council in September. And it's their decision. So in the council meeting in September. So whenever we go. So yeah.
So we've got, you know, on Facebook, we've got people agreeing with you with your comments, Obi, and also pointing out, thank you very much, Asha, that complex care needs and communication are realities, and working with internationally recruited nursing 6 months in English and communication is still an issue, even when they achieved high OET scores. Have I used the right? Well, that's what it says here, so I'll just read that out. That's kind of a point, I suppose, more than a question, but a very valid one as well.
It is a very valid point, and one of the things that our stakeholders are saying to us, and that one thing that we want to work with employers on post this consultation is, you know, it's fine getting people on the register, but what support is given to people when they, you know, start work, in terms of understanding, you know, the particular cultural environment that they're working in, and that, I think, goes to some of Obi's points earlier as well about, you know, inappropriate and discriminatory potentially discriminatory referrals, because people haven't been given the support that they need to understand what's expected of them within the context that they're working in. So yes, and so it's not just about getting on the register, it's about helping people to stay on the register as well.
Mm-hmm. Yeah. Jane, you're on mute.
Oh, sorry, I'm getting carried away looking at, there's lots of comments coming through, I think, to say they're coming through thick and fast, so apologies for that. So yeah, it's just saying the ask is for the review of English criteria. They're concerned that this may well be biased. And then there is another one that, if it's okay, I'll read out. They're saying, yes, I agree. Like in a song, Chain of Falls, there are weak parts and they should be replaced or acted upon. So I think what we absolutely need is those, you know, those parts kind of pointed out. So united we can make a change. Solidarity and good communication are the key. Together we'll be stronger. However, anyone should be given more than 3 chances. So is that reference, Sarah? Do people only get 3 chances at sitting the exam? No,
they can take it as many times as they like. But I think the practicalities are cost, time, preparation time, that kind of thing. So it's
indeed, and maybe that's that. I mean, I may have misunderstood that, and please come back if I have. But you know, maybe that's something that's put on by employers potentially, because as you say, because of the cost. So, but thank you, very valid, those comments, very welcome. So please keep them coming.
Yeah.
I was going to move on to the postgraduate proposals. So it's around accepting postgraduate qualifications taught and examined in English, even in non-majority English speaking countries, as well as using qualifications outside of nursing or midwifery. So Obi, have you got any kind of comments, any concerns about that aspect?
Yes, I do. One of the things that concerns me with this is because I know, again, because, you know, from hearing people's comments, they believe that if they have a degree in English in another subject, whether it be health related or non-health related, that should be good enough. Well, you know, nowadays we know more and more that some of the degree courses are taught kind of like online, and you don't necessarily always have the same kind of person-to-person interaction where you would develop language, learn nuances and colloquialisms and all of the rest of it. You don't necessarily have that, and you could, in theory, almost write your dissertation up in isolation, just with, you know, the comments and things from your supervisor. That would not necessarily prove, whether it be a, you know, BSc or a master's, that would not necessarily prove that you were proficient enough in all the 4 different language domains. It would obviously written, it would be fine, but it wouldn't cover all 4. So again, that gives us some concerns about how you do that to get it right, because we want to make sure that these candidates are able to communicate things which are delicate, which are complex, which are, as I say, colloquialism. You know, we've had all the things about, you know, oh, I'm going to sit on the throne, or I want to spend a penny. All of those kind of things can completely floor somebody if you're doing your experience in one part of the country where those phrases are commonly used, or if you're doing your experiences in a part of the country where those phrases are not used, and then you end up working in a situation where they are common. I mean, it's confusing. The IELTS and the other test both kind of prepare you, is my understanding, to work anywhere. So you could work in Scotland, it would prepare you to work in Scotland, Northern Ireland, England, Wales, wherever. Whereas if we rely on the degree, if we rely on employer references, again, there are some weaknesses in that as a system, I think. And also, we need to really think about neurodiversity, because we know that we have, and people do successfully go through their nurse training, and it's later on it's discovered that they may have, you know, a problem, whether it be dyslexia or other. But I don't know how good we are at looking at that in terms of the international nurses and supporting them through those situations, because, you know, there is often a cost to that, that the organisation would need to take on board. And I'm just, you know, again, it's one of those things that needs to be supported, because again, it could lead to more discriminatory practice.
Yeah, we've had a question come in on this topic. So what post-basic or masters are included on the list? They suggest a degree in art or design wouldn't be fit for the criteria to assess English. So has thought been given to that, Sarah, at this point?
Well, we have thought about it, and actually, if you think about there's an enormous number of courses out there. And at one point we thought, well, should we just do an assessment of all of them and then have a list? And I just don't think that that's practical for us as a regulator to do. So what we are suggesting, potentially, depending on what people come back with, is, well, you know, how you need to just demonstrate to us how your course enabled you to meet all the separate 4 domains, and what about this course enabled you to work in a healthcare context, so that people have an opportunity to demonstrate that, because otherwise we will just have to try and keep and maintain up to a massive list of postgraduate qualifications up to date, which just isn't going to work, I don't think, in terms of an agile system.
And we've obviously had some concerns expressed that people are hearing that this is about lowering the standard. I don't know how you would, I think you kind of touched on it before, but how would you respond to that, Sarah?
That absolutely isn't our intention. I think what we're trying to explore with this is, are there other pieces of evidence that would enable us to be satisfied that the standard that we want and that we're maintaining has been met? Are we being too rigid in our approach, or is there other evidence that we could consider? So the pushback, the challenge to us has been, you're being too rigid, you're not considering other sources of evidence that could give you the same assurance. And that's the bit we're trying to explore. It was absolutely not about lowering the standards at all. It's just about, are there alternative pieces of evidence that can give us the assurance that the standard's being met?
And have you looked at what other regulators do? I mean, how do these proposals differ, or how do you compare to other regulators in this?
Yeah, so I think in terms of the tests scores that we accept, we're largely consistent with other professional regulators here in the UK, and also nursing and midwifery regulators outside the UK. Sorry, excuse me.
No worries.
And I don't know what happened there. Sorry, my phone. So yeah, we are broadly consistent in that sense in terms of the tests we accept. I think other regulators, the GMC and the GDC here in the UK, do accept employer references, but they have a slightly different sort of spin on what they do. And interestingly, some of the feedback we've had from the GMC is that they would say, well, if someone hasn't met the test in the standard and you're going to give a reference for them, doesn't that indicate that your reference, you shouldn't be giving a reference in the first place? Which I think is an interesting way of looking at it. Again, at the moment we're open-minded about it, but when we are broadly consistent with what other regulators. There's no other piece of alternative evidence that other regulators accept that we aren't thinking of accepting, or we're not doing something that's completely, an outlier with other regulators.
In terms of what they're doing, you said they do a different way. I mean, have they had any issues with the way they're doing it? I mean, would you follow the way they're doing it, or are you proposing to do something completely different?
Well, I think the difference from our perspective is that we think we might have a lot of people using this approach, and the GMC, I don't think, have a lot of people using this. Most people at the moment still, use the test. So we don't know how many people might use it. I think our approach is slightly different, because we are saying, well, it could supplement, a reference could supplement a score that hasn't quite met the standard. Whereas the GMC's perspective, and it's a legitimate perspective, is, well, if you haven't met the standard, then how valuable is the reference? And which I personally don't really agree with that, because I think there are situations where you might just miss the standard, but there is, if you get it sufficiently objective, then that some supplementary evidence might just tip you over the line. But it's all to play for, essentially. It's all we want to know what people think.
Toby, I can see you're itching.
Yes, I mean, for me, there are the 4 language domains that people need to pass. Just like when you do your GCSEs or where you do your A-levels, there are set tests that you need to achieve a certain score to pass. People might think that that's strict or whatever, but that's what we have. With this proposal, we're now saying, okay, so we're going to test you and you need to pass 3 and a bit language domains, and then the 4th one, the point, whether it be a 0.5 or a grade or a whatever it's the deficit is, there is a deficit, you are in deficit. We will kind of go around the houses to make that up. So rather than saying, at the minute, we've got 4 language domains which you must pass, we're moving to a situation where you can get, you can have 3, and there's an alternative means to give you the equivalent. So do we then change it and just have 3 language domains and then a 4th alternative way of testing that 4th part? If that makes sense, because it's 4 domains or it's 4 domains. If it's not going to be 4 domains that are clear and straightforward, that needs to change in itself.
I think that's a very fair point. And I come back to the point that actually, although tests aren't perfect, they are the most objective method we have of testing people's capability of practicing safely and effectively. And once you move away from that, or you start to introduce other elements, you are introducing an element of subjectivity. Doesn't necessarily mean it's the wrong thing to do, but it is simpler just to keep with tests and testing those 4 domains, and that's a challenge for us. We want to keep things simple, but we want to keep them fair too. So it's where's that kind of fine line that we need to check. Where's the balancing point for us?
And it's quite interesting because obviously, it's been mentioned that it is a contentious issue, and obviously there are, there's more to it than maybe people might think initially. But given the huge response that you've had, Sarah, how are you going to make sure that people's views are heard, in the main? Because it's quite possible that, there may be a group with a particular view that could, got large numbers of people to respond, so unduly influence the consultation. So how do you make sure that doesn't happen?
So we're working with a group of researchers called Britain Thinks, who do a lot of research in the health and social care sector. And they are, very well qualified researchers. We're gathering a lot of quantitative data, effectively lots of numbers through the survey, the consultation, but they're also doing focus groups as well, so to explore with different types of people what their views are. And they're well aware of the issue that happens with a lot of consultations where there's cut and paste jobs coming in, or cut and paste responses. So they're alive to that issue, and they are capable of weighting the responses. So obviously we've got lots and lots of responses from current registrants at the moment, and less responses from employers. But actually the opinion of employers is very important, especially on references, because they're the people who would have to operate or implement the system. So they have, they'll ask me how they do it, but they have the expertise to get a proper balance in there, so that everybody's views are taken into consideration.
And we are certainly getting some feedback from, people going through the process that, they definitely welcome the change, and the people that are trying to make the change. So thank you for your feedback on Facebook. It's really, really useful, and we will definitely use it. So just moving on, so we don't run out of time, on the test combining and the scores and moving to 12 months rather than 6. What do you think about that, Obi? Have you got any kind of views on that one?
Okay, in terms of, as Sarah said, in what was it, 2019, there was a change in terms of the score that was lowered to 6.5 rather than 7. Again, in terms of discussions that I've had with the members, and it's been people in senior roles as well as clinicians with hands-on patients, they generally seem to feel that that's the right level, that's where the test score should be. However, the opportunity to extend the time of the test to 12 months is favoured. And it's favoured from 2 points of view. One, that if you, because of cost, there's a potential for the cost to increase for everybody. So it allows people to kind of to focus down and do the test when they're ready, and not feel pressured, because the cost of having to do it again and again and again is obviously something that we don't want. But it also gives people the flexibility that, because life happens, and they can, all sorts of things can happen to you in your, in your personal life, your working life or whatever. And it gives people a bit of a chance to live their lives and take the test at the right time when there is less pressure. Because, if people think, oh, my 6 months is running out, but I've still got X, Y, and Z problems, I'm going to take the test, they may well not pass it, which is a great shame. So it gives people flexibility, because life happens and life experiences are real and really valid and should be considered. But also it kind of can help or hinder in terms of cost. So there's kind of two sides to that. But I think that the 12-month is, as an option, is something that we should consider, that should be considered.
Yeah, brilliant. I think the final point on the consultation asks whether, if the standards are changed, whether it should be applicable across the register. So for nurses, midwifery and nursing associates. I don't know any strong views on that. To me, it would seem sensible. You've got, any standard you have to be applicable across. But Obi, what would you say to that one?
Yeah, I mean, I would say, thinking about the standards that we've got, across, it's appropriate for nursing, it's appropriate for midwifery, and in terms of the work that they do, they have to communicate a lot of complex things to their patients, to their clients. They need to understand what their patients' clients are saying to them. And they also need to be able to discuss things at a quite intimate level as well as complex. In terms of, a nursing associate, they may not have to discuss and understand things that are quite as complex, but they still do need to have conversations that are complex. And they also do need to have conversations that are intimate. Therefore, I mean, I would say that it's an appropriate thing to think about the standard being applicable across all 4 parts of the register.
Brilliant. We've had another question that is linked to the consultation. So obviously we need good English language standards, but likewise nurses coming to work in Wales need to learn to speak Welsh. So if you're setting a standard for England, are you setting a similar standard for the Welsh speaking public? Sarah, that's one just for you, I think.
Okay, no worries. So just to explain that we're setting a standard for the whole of the UK. Because that is our statutory responsibility, that's our legal responsibility, that we are legally obliged to make sure that people joining the register can speak and communicate effectively in English. So that's what this consultation is about. I think in terms of the Welsh language, there is a broader point as the 4 countries diverge more and more. I think there's a broader policy point. It may be that government subsequently says, well, actually, you need to have, language specific requirements in each of the 4 countries. For example, you see a greater proliferation of Scots languages as well as Irish languages as well. So there's a whole kind of area there potentially to grow into. For now, it seems to me the broader policy point is best addressed by employers, making sure that the people that they employ are able to communicate with all of the people that they treat, really. But so that's why we're just looking at English, because that's our legal responsibility to do that.
Okay. Thank you. So Sarah, if you could say from your point of view how people can respond to the consultation, and then I'll get you to say something about it as well, Obi, from an organisational point of view. So Sarah.
So there's a link which we can post. I'll make sure I'll post you to the link for the consultation survey and also for the webinar that we held a couple of weeks ago. So there's quite a lot so that's how the best way to respond. So that link takes you to a consultation survey. We think it takes about 15-20 minutes to respond to. We tested it out, and so far people aren't saying it's excessively long. But it's a good idea to read the consultation document first, and it'd be great if people responded to the survey. Obviously, we're saying to organisations like Unite, it's really helpful to have your a consultation response, but a formal consultation response in writing as well as other things, because we recognise that you reflect the views of lots of your members as well. So that's, but I'll send you the links, Jane, Dave and Obi, so that you can put those on the page.
Okay, Obi.
Yeah, so I mean, in terms of members coming back to us, we would love it, firstly, if you sent comments in about the proposals to the Uniting Health inbox, but also very much so, we would really like it if you were able to respond to the consultation as an individual. You know, we've already heard that there's been a fantastic, you know, unprecedented by the NMC response so far. You know, we would love our members to also, you know, make sure that their voices are heard in this. Yes, we will do an organisational response to it. We'll need to get that in. I'm just remembering oh right, there is we had a digest, I think, in last week. No, sorry, I'm getting myself confused. But we will be encouraging and reminding you over social media about where to access the consultation and where to send your responses through.
So I think probably the best website would be healthsector@unitetheunion.org. I think that's fair, isn't it, Obi? And then they'll be passed on to you and you can incorporate them. But I think I haven't got any more questions. So before I wrap up, is there anything else, any final words from you, Sarah?
No, just thank you for this opportunity, and it's been great to have this conversation. So, you know, very happy to continue the conversation as we sort of progress through the consultation. So thank you everybody very much for participating.
And it's the 12th of August is the final day, isn't it? So we would need responses at least a week before that, wouldn't we?
That's right.
Obi, any final words from you?
No, I mean, I think that it's been really good to be able to have the discussion. And I mean, you know, I think it's really good that the NMC is, you know, giving us all the opportunity to kind of like talk through, you know, where it is that they're coming from, why they're proposing what they're proposing. It's clear that they're trying to do something which is helpful. So we need to just think about that and respond whether we support it, or we think that there are other ways that things can be done. So yeah, I mean, I hope that people have found it beneficial.
Thank you. So I'd like to say thank you to you both for your time and for having a good conversation, and thank you, Dave, for doing the technical side in the background. Always appreciated. And thank you all for watching and listening either now or if you're tuning in later. Hope you found it useful, but thank you for all your comments, really useful. We may not have used them all, but we have definitely taken them on board. So thank you very much. Hope you stay safe and well, and have a good evening, and thank you again.
Thank you.